In 1847, a young woman named Mary was wheeled into an operating theater in London. She was conscious. She could hear everything. The crowd of medical students seated in the tiered gallery above was whispering, adjusting their positions for a better view. The surgeon stepped forward, rolled up his sleeves, wiped his hands on his coat, the same coat he had worn for every operation that week, and picked up the blade. Nobody washed their hands. Nobody sterilized anything. And in that room, with dozens of eyes watching, the real danger was not the surgery itself. It was everything else happening around it. The 19th century was a turning point in medicine, but not in the way most people imagine. It was not a century of clean breakthroughs and heroic doctors saving lives with brilliant technique. It was a century of catastrophic mistakes, stubborn ignorance, and a medical establishment that resisted the truth for decades while patients died on tables that should have healed them. The operating theater was, by modern standards, a slaughterhouse dressed in the language of science. And the most terrifying part is that the men performing those surgeries were not evil. They were educated, they were confident, and yet they were completely wrong. To understand how infections were treated in the Victorian era, you first have to understand what surgeons actually believed about disease. For most of the century, the dominant theory was miasma, the idea that illness was caused by bad air, foul smells, the invisible poison floating through the atmosphere of poor neighborhoods and crowded hospitals. It sounds almost poetic in its wrongness. Surgeons walked past rotting tissue, past festering wounds, past patients dying in adjacent beds, and genuinely believed that as long as the windows were open and the air was moving, they were doing everything right. But there was a detail they missed. The concept that invisible living organisms were crawling from their unwashed hands directly into open wounds was not just unknown. It was unthinkable. This belief shaped everything. It shaped how hospitals were built, how instruments were stored, how surgeons dressed, and most critically, how wounds were managed after an operation. A surgeon in 1840 who had just amputated a limb would pack the wound with lint soaked in whatever solution was nearby, wrap it loosely, and consider his job finished. If the patient developed a fever the next day, it was blamed on the air in the ward. If pus appeared, some doctors actually considered it a positive sign. They called it laudable pus, a term that reveals just how deeply the medical establishment had misread the human body. The idea was that pus represented the body expelling corruption. In reality, it was the body losing a war it did not know it was fighting. The mortality rates inside hospitals were staggering. In some institutions, patients who underwent even relatively minor surgeries died at rates that would be considered criminal today. Wound infections, now preventable with basic hygiene, were the leading cause of post-operative death. Septicemia moved fast. A patient could appear stable in the morning and be delirious with fever by nightfall. Gangrene was not rare. It was expected. Surgeons who worked in hospitals during this period did not brag about their survival rates. They moved quickly, they operated with mechanical confidence, and they accepted death as an inevitable feature of their profession. But here is the point where everything changes. Because buried inside this world of miasma and laudable pus and blood-soaked operating coats, a handful of people began asking the questions that everyone else refused to ask. And the answers they found would change medicine forever, at enormous personal cost. The first crack in the wall of ignorance did not come from a famous surgeon in a prestigious institution. It came from a relatively obscure Hungarian physician named Ignaz Semmelweis, working in Vienna in 1847. Semmelweis noticed something that should have been obvious to everyone around him, but it was not. Women who gave birth in the ward, staffed by medical students and doctors, died at dramatically higher rates than women who gave birth in the ward staffed by midwives. The numbers were not close. In the doctor's ward, mortality rates from childbed fever sometimes reached 18%. In the midwives' ward, it hovered around 2%. Same hospital, same city, completely different outcomes. Semmelweis began investigating. He ruled out position during delivery. He ruled out overcrowding. He ruled out fear. Then a colleague of his died after accidentally cutting his hand during an autopsy. The symptoms were identical to childbed fever. That was the moment everything shifted. Semmelweis made the connection that doctors were moving directly from performing autopsies on cadavers to delivering babies, carrying something invisible and deadly on their hands. He introduced mandatory hand washing with a chlorinated lime solution in his ward. And the result? The mortality rate dropped to below 2% almost immediately. He had just discovered the mechanism of infection transmission. And yet, the medical establishment in Vienna destroyed him for it. The resistance to Semmelweis was not just professional skepticism. It was visceral, institutional rejection. Senior physicians were offended by the implication that their hands could be responsible for killing their patients. The idea attacked their identity, their status, their decades of training. They argued against his data, dismissed his methodology, and eventually forced him out of Vienna. He published his findings years later in a book that was largely ignored or ridiculed. He wrote increasingly desperate letters to medical authorities across Europe, begging them to implement hand washing and stop the unnecessary deaths. But nobody listened. Semmelweis died in 1865 in a mental asylum, likely from the very type of infection he had spent his career trying to prevent. The irony is almost too brutal to process. While Semmelweis was being ignored in Europe, a different line of inquiry was developing in parallel. Louis Pasteur, a French chemist, not a physician, was conducting experiments that would eventually produce what became known as germ theory. Pasteur demonstrated through careful controlled experiments that fermentation and putrefaction were caused by living microorganisms, not by spontaneous chemical reactions or bad air. His work built the scientific foundation that Semmelweis had intuited but could not fully explain. Where Semmelweis had the observation without the mechanism, Pasteur was building the mechanism without yet applying it to surgical practice. But then came the person who would connect both. A British surgeon named Joseph Lister. Working in Glasgow in the 1860s, Lister read Pasteur's work and immediately understood its implications for surgery. If putrefaction in organic matter was caused by microorganisms, then wound infection after surgery was almost certainly caused by the same process. The question was not whether this was true. For Lister, the question was how to stop it. He began experimenting with carbolic acid, a compound already being used to treat sewage, as a way to kill microorganisms in surgical wounds. He soaked dressings in it, sprayed it into the air during operations, and insisted on cleaning instruments with it before use. His results were extraordinary. Patients who would almost certainly have died from post-operative infection began surviving. Compound fractures, which had previously carried a near-certain death sentence due to infection, were being successfully treated. Lister published his findings in 1867 and introduced what he called antiseptic surgery to the world. The resistance he faced was significant, but less catastrophic than what Semmelweis had endured. Slowly, surgeon by surgeon, hospital by hospital, the practices began to spread. But the transformation was far from complete. And what came next was more complicated than anyone had anticipated. Joseph Lister had cracked the door open. But cracking a door and walking through it are two entirely different things. The adoption of antiseptic practices across the Victorian medical world was not a clean, rational progression from ignorance to enlightenment. It was a war, fought in lecture halls, in medical journals, in hospital wards, and in the stubborn minds of surgeons who had spent decades building careers on methods that Lister was now telling them were actively killing their patients. Some embraced the new approach immediately, many did not. And in the gap between those two groups, people continued to die from entirely preventable infections throughout the 1870s and into the 1880s. The resistance had layers to it. And this is crucial. Some surgeons doubted the science. Germ theory was still relatively new, still being debated, and a significant portion of the medical establishment preferred to wait for more conclusive evidence before overhauling their entire practice. Others accepted the theory but rejected Lister's specific methods, arguing that carbolic acid was itself damaging to tissue and that the elaborate spray systems he used during operations were impractical and unnecessary. There were legitimate technical debates buried inside the resistance, which made it harder to dismiss entirely as simple stubbornness. But underneath all of it ran something more fundamental. Changing the way surgery was practiced meant admitting that the old way had been wrong, and admitting that the old way had been wrong meant confronting the weight of every patient who had died unnecessarily on a table that should have saved them. It is worth pausing on that for a moment, because the psychological burden of that realization was not abstract for these men. They had names, they had faces, they had families who had been told that everything possible had been done. The surgeons who most aggressively resisted antiseptic practice were not necessarily the most ignorant. Some of them were among the most experienced, the most decorated, the most respected figures in their field. And experience, in this case, had become a trap. The more operations a surgeon had performed under the old system, the more deeply invested he was in the belief that the system worked. While this institutional battle was playing out, actual patients were living and dying inside its consequences. For someone admitted to a Victorian hospital with a serious wound infection in the 1870s, the treatment options were brutal and limited. Surgeons would irrigate wounds with whatever antiseptic solutions were available, ranging from carbolic acid in more progressive institutions to simple water or wine in others. Abscesses were lanced and drained, sometimes repeatedly. Gangrenous tissue was debrided, meaning cut away, often without adequate pain management. If the infection had spread too deeply into a limb, amputation remained the default solution. It was fast, it removed the source of infection, and in the hands of a skilled surgeon, it could be completed in under 2 minutes. Speed was not a choice. It was a survival mechanism for the patient, since anesthesia, while available by this point, was imprecise and carried its own serious risks. Chloroform and ether had arrived in the 1840s, transforming the experience of surgery in ways that were immediately and viscerally apparent. Before anesthesia, surgical speed was merciful necessity. A patient who was conscious and screaming could die from shock before an operation was finished. After anesthesia, surgeons could slow down, be more precise, attempt more complex procedures. But this created an unintended consequence that took years to fully recognize. Longer operations meant longer exposure to the unsterile environment of the operating theater. Anesthesia extended the time during which infection could take hold. It made surgery more survivable in one dimension while making it more dangerous in another. And the full weight of that trade-off would not be understood until antiseptic and later aseptic techniques became standard. By the late 1880s, the tide was beginning to shift decisively. A new generation of surgeons trained under Lister's principles was moving into positions of influence. The evidence had accumulated to a point where denial required more effort than acceptance. And a new concept was beginning to emerge that would push beyond antisepsis entirely. The idea of asepsis, not just killing germs that were present, but preventing them from entering the surgical environment at all. Sterile gloves, sterile instruments, sterile gowns. A complete reimagining of what an operating room could and should be. The transformation was almost complete. But there was one more piece to the puzzle. The shift from antisepsis to asepsis did not happen overnight, and it did not happen peacefully. But by the final decade of the 19th century, the architecture of modern surgical practice was being assembled piece by piece, and the results were undeniable. William Halsted, an American surgeon working at Johns Hopkins, introduced sterile rubber gloves in the early 1890s, initially to protect a nurse's hands from the harsh chemical solutions being used, not yet fully understanding that the gloves would also protect the patient from the surgeon's hands. The irony of that origin story carries its own weight. The single most important piece of protective equipment in surgical history was invented backwards. Solving the wrong problem first and accidentally solving the right one in the process Ernst von Bergmann in Germany was developing steam sterilization for surgical instruments during the same period, replacing the chemical soaking methods that Lister had pioneered with a more reliable and thorough process. Operating rooms began to be designed specifically around the principles of contamination control: surfaces that could be cleaned, lighting that eliminated shadows, layouts that minimized unnecessary movement and therefore minimized the spread of microorganisms through the air and across surfaces. The operating theater of 1895 was barely recognizable compared to the one Mary had been wheeled into in 1847. The gallery of observing students was gone. The blood-soaked coat was gone. The casual conversation across an open wound was gone. What replaced it was something closer to a controlled environment, still imperfect by modern standards, still missing the antibiotics that would not arrive until the 20th century, but fundamentally transformed in its understanding of what infection was, where it came from, and how to prevent it. The mortality rates reflected this transformation. Post-operative infection deaths that had been routine and expected became progressively rarer. Surgeries that had been considered near-certain death sentences became survivable, then commonplace, then routine. But the story does not end cleanly with triumph. Because the Victorian era left behind something more complicated than a simple narrative of progress. It left behind a record of how institutions resist truth when truth is inconvenient. Semmelweis died ignored and broken, while the solution he had discovered sat unused in the medical literature for nearly 2 decades. Entire generations of patients died from infections that hand-washing alone could have prevented, not because the knowledge was unavailable, but because the people with the power to implement it refused to accept its implications. The Victorian surgical theater was not just a place where bodies were repaired or failed. It was a place where the collision between human ego and empirical evidence played out in the most literal terms possible, with lives as the currency of the argument. There is a reason this history matters beyond its own era. The pattern it describes. Of institutions protecting their established methods against new evidence, of individuals facing professional destruction for questioning accepted practice, of patients bearing the cost of that resistance. Did not end in 1900. It has repeated itself across medical history in different forms, with different diseases and different technologies, but with a recognizable structure. The Victorian surgical crisis was not an anomaly, it was a template. What Semmelweis, Pasteur, and Lister collectively demonstrated was not just that germs cause infection. They demonstrated something harder and more uncomfortable. That knowing the truth is not enough. That truth requires advocates willing to fight for it against institutional inertia, sometimes at enormous personal cost. And that the distance between a discovery and its adoption can be measured in years of preventable suffering. Mary, wheeled into that London operating theater in 1847, had no way of knowing that the knowledge to save her was already forming in the mind of a physician in Vienna. She also had no way of knowing that it would take another 20 years before anyone with the power to act on it finally did. The operating table has always been where medicine faces its most honest reckoning. In the Victorian era, that reckoning came slowly, painfully, and far too late for far too many. But it came. And every sterile surface in every modern surgical suite is, in a quiet way, a monument to everyone who died before it did.